Okay.
Yeah.
So, good evening, everyone in India. Good afternoon in UK, and good morning in Canada. And on behalf of Ankura Hospitals, I invite you to our webinar series. And today we'll be talking about cardiopulmonary interactions. I would like to introduce our moderator, Dr. Sairam. He is one of the consultants at Ankura. He has completed his FNB in pediatric critical care from Rainbow Children's Hospital. And cardiopulmonary interaction happens to be one of his topics of interest. Over to you, Dr. Sairam.
Thank you, Dr. Nikhil, for the introduction. Good evening, everyone. Today we have an esteemed team to deliver this talk, and we are very fortunate to hear from the legends of PSU, and they are joining from almost on 3 continents, one from Canada, from UK, and the speaker from India. So I take the privilege to introduce panelists today. Coming to the speaker, Dr. Parag Shankarrao Dekate. Sir has done his pediatrics and fellowship from prestigious PGI Chandigarh, following which Sir has done his fellowship from Sick Kids Toronto. Sir is currently the Director of Pediatrics and Head of Pediatric Intensive Care, KIMS Cuddles, Hyderabad. I'm one of the fortunate fellows to get trained under Dr. Parag. He was more than teacher for me and a constant source of inspiration. Coming to the chairpersons for today's session, they need no introduction. Dr. Biseda Mema, MD FRCP, Staff Physician, Pediatric Critical Care, Residency Program and Fellowship Director, Associate Professor of Pediatrics, the Hospital for Sick Children, University of Toronto, Canada. Welcome, madam. Our next chairperson for today, Dr. Intikhab Jafarullah, Dr. Jaf. He's a consultant PICU and KIDS, Pediatric Critical Care Program Director of Birmingham Children's Hospital. He's a medical chair, IAC for a VPICS 2022. He is also a volunteer cardiac intensivist for Chain of Hope UK and Gift of Life US charities. And sir is from Birmingham Children's Hospital UK. Welcome to all the panelists and to the speaker. Now I would like to request Dr. Biseda Mema to start the discussion and then pass on to Dr. Parag for the webinar.
Thank you so much. I was thrilled actually to be asked by Parag to join this webinar. And I am the program director at Sick Kids, and Parag was a fellow with us, so was Zaf. And so it was very nice to see them both today. They both have a very special place in my heart. And I remember Parag when he started, he was an outstanding clinician. And most importantly, every time he was around, the atmosphere was very positive and he was always smiling. And so it's very nice to see him smile this evening in India and this morning for me.
Yeah.
And so Parag told me that he is speaking about cardiopulmonary interactions, and here philosophy and physiology match. So at a philosophical level, you know, everything in life is interconnected, and so are the heart and lungs, and so is the organism. And it is many times much easier to simplify things and key concepts. And so we focus on only one thing. We focus only on the heart, or we focus only on the lung. But as Albert Einstein said, everything should be made as simple as possible, but not simpler. And so I'm looking forward to this talk, and I know that Parag will be able to give us a very nice summary. Thank you.
Zaf, you wanted to say something?
I know, I'll catch up after you have presented.
Good. Thanks, Sairam. Thanks, Ankura Hospital. Thanks, Biseda, for nice overview kind of a thing before starting. So today, actually, I personally like this topic of cardiorespiratory interactions. The reason behind this thing is, means it is very easy to get confused in this. At the same point of time, when we are learning about it, it becomes initially we feel we are actually learning it and it's very simple. But more and more we go into the details, we understand it's interrelated and a little bit complex. But once we got the hold of this cardiorespiratory interaction, managing the other things become really, really easy. So how I'm going to go through this is a little bit of history, which probably doesn't add into the presentation per se. A few concept of transmural pressure and main systemic failing pressure, because these are the very two important things which we have to understand when we are thinking about a cardiovascular interactions or cardiopulmonary interactions, because most of the things, pressures, which are probably intrathoracic or intracardiac pressures, there is an interplay between the transmural pressure and mean systemic failing pressure. Then we have the volume and pressure flow relationship, which dictates the different zones in the, I would say, in the lung as well as in the capillary system into the whole body. And then we'll come to the per se, what is an effect of respiration on heart with respect to the right ventricle, left ventricle, preload and afterload. So we'll dissect each of these things succinctly. And the last one is what is a clinical implication of these cardiorespiratory interactions? What exactly happens? So I have a couple of case scenario where actually we would try to see how our clinical things changes the cardiorespiratory interactions in a different sets of patients. So briefly, so if you see the history goes beyond around 1600, where they found out heart as a pump, and then they tried to find out there's a lot of network of capillaries and veins all over the bodies. And in 1773 Hales, what he found out is that there is a pulsatility of flow, because initially it was found to be there is a continuous flow, but then he found out that there is a pulsatile flow. And up till now, actually, the pulsatile flow is kind of a very prominent physiological marker which differentiate a normal waveform pattern as compared to the other extracorporeal circuit. Like we have an ECMO where there is a continuous flow, but at the most point of a time, what is required for the vessels, and the vessels has been grown up from beginning with the pulsatile flow. And over the time, there's a lot of modifications over the invasive studies, and more we came to know about what are the different pressures. It could be right atrial pressures, pulmonary capillary wedge pressures, and transmural pressures. So if you see the Theodore, what he did is actually he catheterized himself to find out what happens and what are the different pressures we usually see in kind of a normal patients, which you can see, imagine in 1904 he did that, and he are able to catheterize the heart through the peripheral veins and able to say there are different kind of pressures exist in the bigger vessels and the cardiac vessels. So this is kind of a turning stone where the pressures are actually different in each and every part of the vascular system, starting from the heart and going back to the other peripheral vessels. So over the time, this is a published study. You can see American Journal of Physiology. It's a very kind of a pioneer initial studies where they found out what happens to the positive pressure breathing on the cardiac. What is it? What is an impact of a positive pressure ventilation in the cardiac output? And if you see, what they have seen is, you are able to see my cursor. Yeah. So a very desirable type of intermittent positive pressure breathing should provide a pressure. So what they have seen is a gradual increase in the pressure during inspiration, which is obvious, a rapid drop in the pressure after cycling occurs, and a mean mass pressure during the expiratory. So what they have found is there is a change in the cardiac output with change in the intermittent positive pressure breathing. So this is kind of a initial study which is published in 1947, which gives us that the pressures are not same throughout the respiratory cycles, and it is a complex interplay between the thoracic pressures and the intracardiac pressure or a transmural pressure across the heart. So over the time, there is a lot of research happened over this to understand what exactly happens with the positive pressure breathing on the cardiac output. So if you see the basic things which comes first is what is transmural pressure, because if you see in the heart, so we have a heart and surrounding the respiratory, I would say, lung. And there is a constant pressure which is built inside the heart muscles as well as outside. So outside, what is the pressure outside? It could be, most of the times, is a transpulmonary pressure, which can be changing depending upon where our positive pressure ventilation or spontaneous breathing. So you see, this is the pressure exerted. So transmural pressure is what? a difference between the inside and surrounding pressure. So this is the surrounding pressure. For the heart, most of the time it is thoracic pressure, or you can say transpulmonary pressure. And inside, what is this? We have considered this is as a right atrium. So you can, this is a right atrial pressure, and the pressure difference between the two is transmural pressure. So these are few examples. You can see inside the cavity, there is a pressure of 15, and outside it is 10. So just imagine this is kind of a positive pressure ventilation where there is a positive intrathoracic pressure. So the difference between the two is 5. So there is a 5 transmural pressure. So what is the meaning of a 5? Lower the transmural pressure, there is a less capacity of a, I would say, any structure to distend. That means it is less accommodative. It is, you can consider it is collapsing or kind of a more stiffer. But at the same point of time, you see the second thing. What is happening is the internal pressure is 15 and outside pressure is -5. So you can say it can be related to the spontaneous breathing, where is a normal negative pleural pressure. Or you can say you are dealing with some kind of a conditions where there's a more negative intrathoracic pressure. You can say bronchial asthma, bronchiolitis, and the continuous transmural pressure. You can see 15 minus -5. So basically, it will be an addition of a 5. So the transmural pressure is 20. What it means is this RA is more accommodative or probably distensible structure. Similarly, you will see the third scenario. What is happening is, again, the things are same, and the transmural pressure is 20. But the difference between all of them is definitely the size. But at the same point of time, if you see the structure of a wall or a thickness of a wall has a less impact on the transmural pressure. So it's not like that if you have a left ventricle which is very, very stiff, though you have a different coronary perfusion pressure or a myocardial demand or myocardial perfusion pressure, but the transmural pressure would remain the same depending upon what is an inside pressure, what is an outside pressure. So what is transmural pressure? As we discussed, is an what we do is when we catheterize RA or we catheterize LA, we try to see the pressure inside, and we know the pressure which is outside depending upon what is a mean airway pressure, and we try to get the transmural pressure here. So what is transmural pressure? I said outside pressure as well as inside pressure. So basically it's a working pressure of the heart chamber or any blood vessels within the thorax, because in the thorax there is a complex interplay between the intracardiac pressure and probably an outside pressure, which is mainly thorax. And transpulmonary pressure. What is transpulmonary pressure? This is a working pressure of the lung within the thorax, which is related to the alveolar pressure, airway pressure, and the pleural pressure. So transmural pressure is related to the working pressure of the heart chamber. And as I told you, transmural pressure, if it is positive, it distends the structure, or probably it can, you can say it is more accommodative. And if it is negative, it decreases in the size or collapses the structure. So a positive transmural pressure probably able to gain more kind of a volume into the any cavity as compared to the negative transmural pressure. So now coming to the mean systemic feeling pressure. So what is mean systemic feeling pressure? Before that, I just wanted to tell you about what we called as a stressed and unstressed volume. This concept probably came in the last 5 to 6 years. What is stressed and unstressed volume? Because over the time we found out that giving more and more fluid bolus is not improving the kind of a condition of a child. And then we realized why the child needs a fluid bolus or a patient needs a fluid bolus. We are giving it, but actually it is not getting into the desired physiological response in the form of improvement in the heart rate or improvement in the blood pressure. So what is happening? So then came the concept of stressed and unstressed volume. So actually, there is one physiologist or a pediatric intensivist. His name is Bagder. It's from McMaster. No, not. He's from the Canada. So Montreal University. He was the one who actually gave a bathtub theory, and then there was an over the time concept of stress volume. So what is the stress volume? This is the cavity. At any point of time, if you see the median chamber of a blood column or a volume or anything, it is not producing any pressure over the walls. So this is just constantly flowing. But this is a column which is coming in contact over the blood vessel, which is exerting some pressure. So this is called stress volume. So any fluid or any fluid bolus or blood volume or colloid or crystalloid should transcribed into improvement in the blood pressure should be stress volume. In the sense, so in any point of time in our body, the stress volume is only 30%. So 70% is unstressed, which is not causing any pressure over the any vessels in the body. And once we go into the phase of a sepsis, septic shock, or probably hypovolemia, what happens is more and more volume goes into the stress. So from 30%, it will become 40, 50, 60, depending upon the things. And if the child requires more fluid bolus, and we give a fluid bolus, and that fluid bolus changes into a stress volume, then only you will have an improvement in the blood pressure. Otherwise, it will probably seep in or probably stay inside the body in the form of an unstressed volume. So this is very important. But from where this concept came? So this concept came from mean systemic feeling pressure. So what is mean systemic feeling pressure is, if you stop the circulation at any point of time completely, for some time, what will happen? The blood will redistribute all over the body, whatever the vessels, heart, whatever you have it. And after some time, it will exert some pressure over the walls. So this is called as a mean systemic feeling pressure. This is probably kind of you say it's a driving pressure for this blood to go back to the heart. So this is called as a mean systemic feeling pressure. And they are different. If you see, you have arteries, capillaries, veins, central veins. In a normal circulation, you can see the mean pressures probably on the higher side from 70. Then you have a profound shock, where what happens, the mean systemic feeling pressure goes down. And this is mean systemic feeling pressure when there is no circulation, there is no pulsatility. Most of the time it stays same. So it's not like that. Once you have a circulatory arrest, there is no pressure exerted over the wall. Definitely in the circulatory arrest, there will be some pressure exerted by this blood column onto the walls. So again, same thing. If you see a little bit of a blurry diagram, but if you see, so this is an artery which is pumping blood into the veins. So this is, let's just assume this is a venous reservoir, depending upon how much venous capacitance you have. And this is gonna bring some kind of a pressure. So this is basically a chamber which is providing some pressure for the blood to go from all the venules or veins towards the right atrium. So this is kind of a driving pressure, or probably you will say a chamber which is pumping, not pumping actually, which is causing a pressure over the venous blood to go towards the RA. So the blood flow to the RA depends upon what is the pressure into the RA, what is the resistance of this tube. If this resistance is increased, so definitely the blood flow to the RA will be less. And what is the mean systemic feeling pressure? How much is this pressure? If the mean systemic feeling pressure goes down, what will happen? Definitely the return to the right atrium will go down. So if the right atrial pressure grows up, the difference between the mean systemic feeling pressure and the right atrial pressure will become less, so that the less blood will go into the RA. Third thing is, if the resistance of this tube goes up, so definitely the less blood will go into the RA. So it is just not about the how much fluid bolus you are giving. It depends upon the RA pressure, it depends upon the resistance as well as the mean systemic feeling pressure. Again, if you see the same thing in any patient who in a stress situation get a sympathetic stimulation. So this is a venous return and cardiac output. So what happens in a sympathetic stimulation? So probably all the vessels get probably constricted. So what happens in the constricted vessels? The more and more blood goes into the you can say mean systemic feeling pressure or your venous tank. So the mean systemic feeling pressure goes up, and probably the venous return to the heart goes up. But normally this is maintained in the, I would say, controlled way. Slowly, once you started having a damaged myocardium where you don't have much of an inotropy, what happens is, if you see the increase, there is a means capillary feeling pressure is increases, because less and less is blood going into the RA. So more and more is blood is going stagnated into the venous capacitance, or in another way we usually call it's congestion. So those things happen when you have a different kind of a scenario related to the sympathetic stimulation, normal and damaged myocardium. So the venous return and the cardiac output differentiate with respect to the sympathetic stimulation, normal and the damaged myocardium. So as we told, the pressure within the systemic venous reservoir is equal to the mean systemic pressure when there is no circulatory or there is no circulation and circulatory arrest. So as I told you, there will be a redistribution of a blood in the entire circulation, and there will be an equilibration. So the Guyton, this study was done approximately in 1970s. What we found to that, the mean systemic feeling pressure is around 7. So that means the venous capacitance pressure, or where there is a lot of blood staying pulled, is 7. Normal mean atrial pressure is around 2 millimeter. So that means the RA pressure is 2 millimeter. The mean systemic feeling pressure is 7 millimeter. This is in the dog after the circulatory arrest. So still there exists a driving pressure, or probably you can say driving pressure for the systemic venous return to the RA is around 5 millimeter. So it's a very low flow system, but this is very, very crucial for whatever we are giving to go back to the RA. So again, similar thing as I told you, this is probably you can consider as a venous reservoir or mean systemic feeling pressure. This is an arterial blood going into that chamber, and this is the venous nodule where the blood will go into the RA. Similarly, the column. So if you see one and one thing, so this is an arterial flow. This is a systemic venous reservoir. The water or blood will how much water comes out of this nozzle depends upon the diameter of the hole. If the diameter is more, so definitely the more blood will come out, and the height above the hole. So if you consider the height goes below and below, so probably less and less blood will come out. If it goes up, more and more blood will come out. So venoconstriction is represented by the downward. So if there is a venoconstriction, this will go down because the resistance will go up. And if it is a venodilatation, there will be an upward displacement because it will become very easy for this blood to go to the RA. So it's a simple, we call it a bathtub's query. So that comes to, after understanding this mean systemic filling pressure and transmural pressure, which is very important in understanding the cardiorespiratory interaction. Let's talk about cardiorespiratory interactions. So what we know is it's a complex play between the thorax, abdomen, peripheral, and all other circulation. But mostly it lies in this quadrant where there is an interplay between the intrathoracic pressure and vascular pressure. So the cardiorespiratory system is subjected to the various pressures. Intrathoracic pressures in each and every respiratory cycles, they are different depending upon what kind of a physiology is predominating at that point of time. So, and it's a complex interplay between intrathoracic pressure, lung volume, gas exchange, and there are a lot of things happening into the heart in the form of venous return, ventricular performance, arterial outflow. So we're going to see each and everything slowly with related to the cardiorespiratory interactions. It goes back to the same principle of physics, which is a law of hydrodynamics. What it says, any distensible and compressible structure had a simple law, which depends upon what is the inflow pressure, what is the outside pressure, and what is an outflow pressure. And this applies to the capillaries everywhere in the body as well as into the lungs. So let's talk about it. The behavior of the flow, that means whatever is going through the collapsible structure, it can be a tube, a vessel, or veins, artery. It depends upon the inflow pressure. So what pressure it is going in, outflow pressure, what pressure it is coming out, surrounding pressure. What is transmural pressure? As we learn, it's a pressure difference between around the walls and the compliance of the structure. So let's talk about it. So this is basically a pressure volume relationship, pressure flow relationship. So again, Starling flow. So this is an inflow pressure. So this is a surrounding pressure. There is an amount of blood going through this, and there is an outflow pressure. So if this inflow pressure is more than the surrounding pressure and more than the outflow pressure, definitely this blood will go out. But there are different kind of a scenario exist in our lung in the body depending upon the inflow, outflow, and the surrounding pressures. So let's talk about it. And the flow through this depends upon, so how much flow is going to happen through this resistor depends upon the inflow pressure, the outflow pressure, and the resistance of this tube. So which is the flow depends upon the inspiratory or inflow pressure minus outflow pressure divided by the resistance. And the resistance per se, what is resistance? It depends upon the transmural pressure. So surrounding pressure and inside pressure. So as we see, driving pressure is PI minus PO, inflow and outflow pressure. Transmural pressure is what you called is surrounding pressure minus inflow pressure, and R is an intrinsic resistance of the tube. So these are the three different zones we encounter in any part of the body, you can say like that. Most of the time we use this kind of a terminology when we are talking about the lungs. We'll come to that. So we have a zone 3. So what is zone 3 is inflow pressure is more than the outflow pressure, more than the surrounding pressure. So at the end of the day, how much is the flow goes through this? It depends upon the inflow pressure and outflow pressure, because there is hardly any resistance for this because the surrounding pressure is less than the outflow pressure. Then we have a zone 1. So what happens in a zone 1 is the surrounding pressure goes very high. So you can say where it happens, surrounding pressure goes very high. It could be interstitial edema. It could be, you can consider in the lung as hyperinflation, where you cause a kind of pressure over the vessel wall. So those kind of things you see both in the hemodynamics or capillaries as well as in the lungs. So what is happening here is the surrounding pressure is very high as compared to the inflow pressure. So that means there is a complete chinking of the wall, or you can say the transmural pressure is very, very low. So it's a collapsible structure. So, and the resistance is very, very high. So if you see the transmural pressure becomes negative, as I told, it becomes low, that means negative, and the tube collapses and hardly there will be any flow. So what is happening, we'll talk about it, what it represent in the lung as compared to the VQ mismatch or shunting. Then you have a third scenario, which is zone 2. Inflow pressure is more than the surrounding pressure, and the surrounding pressure is more than the outflow pressure. This is most of the time you see in this kind of a thing. And if you see, the flow through this wall mainly depends upon two things, because outflow pressure is low than the surrounding pressure. So mainly it depends upon what is an inflow pressure and what is the surrounding pressure, which will decide how much blood is flowing through this tube. So these are the three zones you usually encounter in circulation as well as in the lungs. So if you talk about lungs, so we see these three kind of a zones. So you have a West zone 1. So what is happening is here, the alveolar pressure is higher than arterial pressure, and arterial pressure is higher than the venous pressure. So what is exactly happening here is, does not normally, so usually you don't see this zone, but it can be seen mainly when you are thinking like a bronchial asthma or obstructive lung disease. What happens in there is an elevated ventilation, but there is no perfusion. So the alveoli are getting balloon and causing an intrinsic compression of the vessels. So you kind of have a dead space ventilation. Then second zone, what you see is the arterial pressure is more than the alveolar pressure. So your arterial pressure is able to transcribe through the alveolar pressure, and the alveolar pressure is more than the venous pressure. So this is kind of a comfortable zone where the ventilation is matching with the perfusion, and you get a ventilation perfusion matched. And then you have a third zone. What you see in the third zone, the alveolar pressure or arterial pressure is more than the venous pressure, and the venous pressure is more than the alveolar pressure. So what happens here is you started having elevated perfusion and the reduced ventilation, and you started having shunting because there is nothing happening from the ventilation point of view. So these are the three things usually you see in lungs zone, and most of the time zone 2 is commonly, and zone 1 in bronchial asthma, everything changes to the West zone more and more if you don't take care of the patient in the early phase of the disease. So once understanding the zones, transmural pressure and mean systemic feeling pressure, let's talk about what exactly happened with respect to the right ventricular preload, afterload, left ventricular preload and afterload with respiration, which could be a spontaneous or positive pressure ventilation. So let's talk about right ventricular preload. So as we discussed, there is a transmural pressure as well as there is a mean systemic failing pressure, which is dragging the blood into the, or which is promoting the blood go into the RA. So the pressure gradient, it could be peripheral to central to the venous structure. It could be systemic venous reservoir to the right atrium. So the blood from the peripheries, it could be venules, capillaries, should go to the bigger veins, and from bigger veins, it should go to the right atrium. As we discussed, it depends upon what is a mean systemic feeling pressure, what is the resistance of the veins which the blood has to go through and reaching to the RA. Again, few things which are very important in estimating how much of blood is going into the RA is viscosity of the blood, collapse of the vena cava. So collapse of the vena cava in the sense the interplay of thoracic pressure with respect to the bigger vessels which comes into the thoracic inlet. And what about the, I would say, mean systemic feeling pressure. So the effect of preload can be described by 3-4 things. One is the pressure gradient, the resistance of the vessels, as well as mean systemic feeling pressure. So how it helps us, let's see. So in the basic physiology, we know that the FRC, which is the FRC which we achieve at spontaneous breathing and a positive pressure ventilation, there is a difference of a pleural pressure. So when you are on the positive pressure ventilation, the pleural pressure which is required to achieve a desired FRC, definitely it is higher as compared to the spontaneous breathing, where you definitely achieve the same FRC with the less pleural pressure. So definitely we know that there is a different intrathoracic pressure which is going to exert their pressure over the heart vessels or vasculature with respect to the functional residual capacity. So this give a basis towards the RV preload. So if you see, when you are under positive pressure ventilation, so you're going to have a positive thoracic pressure, which is going to cause a pressure over the RA and RV. So definitely what is going to happen is your transmural pressure is going to change. Similarly, if you see here, systemic venous return. So let's talk about arterial pressure. So if your right atrial pressure is equal to the mean systemic venous pressure, that means let it be you achieve a situation where your RA pressure is same as the mean systemic venous pressure. That means there is no pressure difference between the two. So what happens is you come to the phase where there is both things are nullified. It's like a similar circulation. There is no driving pressure. Everything is like a seamlessly going because there is no pressure difference between the two, which is possible, but theoretically we don't see this kind of a situation. Let's talk about positive pressure ventilation. What happens in a positive pressure? Positive pressure ventilation will increase the right atrial pressure. As we see, it's going to cause a lot of pressure over the RA. So it's going to cause pressure over the RA. What will happen ultimately is RA will become, so the transmural pressure in the RA, because let it be there is a pressure of 5-6, CVP is 5-6, and you have a positive pressure ventilation where the PEEP is, let it be 8. So what is going to happen is the difference between the two is in the minus, because 7 minus 8, so minus 1. So the RA is going to become more kind of a less compliant and change. So what will happen is there is the increase in the right atrial pressure. There will be a less kind of a space. So the RA pressure will go up. The RA will become less compliant as compared to the spontaneous breathing. What happens in the spontaneous breathing is, if you see, the right atrial pressure is optimized as well as the venous return is also optimized, because you have a change in the pressure with respect to the spontaneous breathing, and the RA is more accommodative because you are generating a -5 or -6 of a pleural pressure during the spontaneous breathing, and that is creating a positive transmural pressure over the right atrium, and the right atrium is more accommodative. If it is more accommodative, the RA pressure is low, so there will be a constant kind of a gradient between the mean systemic failing pressure or a driving venous pressure and RA pressure. So intrathoracic pressure and preload. So if you see, the venous return depends upon what is your mean systemic failing pressure minus RA pressure. So this is basically a driving pressure. Mean systemic failing pressure is the pressure into the veins, capillaries when there is no flow. And what is the resistance of the through which it is going on? If you remember, I showed one diagram where there is a reservoir and there is a tube. So the resistance of the tube is also important. So mean systemic pressure is a circulating pressure at zero flow, what we discussed, mainly extrathoracic, depends upon circulatory volumes and venous capacitance tones. So if you remember, there are a lot of conditions clinically, we'll talk about it, like giving muscle paralysis, not allowing the child to move, completely keeping them sedated, all those things affect the venous capacitance. Remember, in the spontaneous respiration, there is a negative intrathoracic pressure and the venous return will go over. Definitely, as we discussed, the transmural pressure over the RA will be more. So the RA will be more accommodative, and inversely happens in the positive pressure ventilation. The intrathoracic pressure is high and the venous return will go down. And there are few conditions which can kind of complexly interplay when we are happening all those things, because these are not going to happen in one set like de novo. There will be other things happening at the same point of time. The few of the thing is the child might be having a hypovolemia. It might be related to the baseline condition, venoconstriction, depending upon what kind of an adrenergic response this child is. So these things will change, but ultimately it all depends upon the transmural pressure, RA pressure, and the resistance. So again, similar thing what we have discussed about RA pressure. So you have you have a condition where you can see the RA pressure is 8, or you can say the transmural pressure is 8, and the venous return, if you see, 1 minute. Okay, so we might reach a situation where the venous pressure falls to that extent that it equilibrates to the RA pressure. So that means we reach a situation where transmural pressure in the sense, not transmural pressure, the mean systemic failing pressure or the driving pressure is 0, or the pressure which is driving the blood to go into the RA, and the RA pressure is 0. But actually, theoretically, it doesn't happen. But in that situation, what will happen? The venous return will be 0 because there is no difference between the two. We need a driving pressure. So this definitely the transmural pressure should be more as compared to the RA pressure to drive the blood into the RA. So another thing which is very important here is increase in the venous return as the intrathoracic pressure falls in inspiration is not limitless. That means let us assume that we have a negative intrathoracic pressure, and we know that more and more negative intrathoracic pressure, we will get a venous return. But does it mean that if my intrathoracic pressure goes to -20, -30, -50, I will have more and more venous return into the RA? No, it is not like that. That means the RA, the transmural pressure of the RA increases to the certain extent, then only the venous return will go up. And after that, even increase into the transmural pressure of the RA, there will be no improvement in the venous return. So this is very important. So it is not limitless. So there is a I would say there is a elastance of the each and every part of the heart, which will be very, very important from case to case basis for the venous return. And if you see this situation, severe fall into the intrathoracic pressure or RA pressure, there is no effect on the venous return as flow, no function of the venous return. So we are talking about this situation. Now the venous return is a flow, as a flow now a function of a transmural pressure and atmospheric pressure as thoracic inlets. In the sense, when we reach this situation where your RA pressure and the mean systemic pressure are same, it all depends upon whatever the pressure changes happening into your tummy, because tummy pressure becomes positive, it will push the blood into the RA because there is no gradient. So depending upon this situation is kind of a theoretical, probably might not happen in the usual lifestyle. So we discussed about the effect of respiration on the preload. So mainly if it is a spontaneous breathing, what happens is your preload increases, RV preload. If it is a positive pressure ventilation, the RV preload goes down. So let's talk about the RV afterload. What happens? So we know when we are talking about RV afterload, we are talking about the pulmonary vascular resistance, which is most important. And we know the pulmonary vascular resistance depends upon a lot of things. It depends upon the clinical condition of a child, what is a myocardium, what disease we are talking about, lung volumes, different. So there are two types of blood vessels we should be worried about when we are talking about the pulmonary vascular resistance. One is the septal and another one is corner. So basically what is septal? What we call as a alveolar vessels, which lies between the walls of the two alveoli. And corner vessel is basically at the corner, like there are junctions of several alveoli. In between that, you will see that extra-alveolar vessels. We will see the diagram of that. And the total pulmonary vascular resistance depend upon basically is the sum of septal and corner. So it's not basically a differentiation between the septal and corner. These two vessels together will add to the pulmonary vascular resistance. And remember, the pulmonary vascular resistance is lowest at functional residual capacity, and that is the funda of ventilation in any of the child with any kind of a disease in the form of, you say, you talk about any ARDS and all other things. So FRC has to be mentioned. And PVR depends upon a lot of other things: alveolar oxygen tension, lung volumes, and pH. So we have alveolar vessels and extra-alveolar vessels. As we discussed, alveolar vessels are mainly related to the walls. There are small, there are capillaries, venules. Mainly extra-alveolar vessels are bigger and they lie outside, and both the vessels are in a series, provides the resistance in addition. So these are the vessels. You can see these are the septal vessels and these are the corner vessels. Septal vessels are related to the alveoli. And you will see what is happening is once the total lung capacity is going up, what is happening is pulmonary vascular resistance in this septal wall is going up, because you'll see in the next thing. So what is happening is this is things is happening. These are the septal blood vessels or alveolar blood vessels. So when you have an overinflation, total lung capacity increases. What is happening? There is a complete stretch over the alveoli, and which completely blocks the alveolar vessels. And what happens is you started having a high PVR, and then you started having intrapulmonary shunts and hypoxia. What happens in atelectasis is, in atelectasis, most likely it is possible that your alveolar vessels are open, but because of the complete atelectasis, the corner vessels become smaller, and you started having the problems related to the oxygenation as well as, so you started having the VQ mismatch here. And there are a lot of other things happening simultaneously in the form of alveolar recruitment, decreased hypoxia, pulmonary vasoconstriction. So you wanted to go to achieve all those things, you have to ventilate the child in the FRC. And if you see, so pulmonary vascular resistance is least when you achieve a phase when you are at a functional residual capacity. This blue curve says about the extraalveolar vessels, and this talks about the alveolar vessels. Similar thing which is depicted, you can see when we are actually over distending, we have the vessels are becoming smaller. When you are at the FRC, everything going fine. When you are atelectatic, again, what is happening is the corner vessels are getting affected. So right ventricular and pulmonary vascular bed. So we know that RV is a low pressure circuit, and blood flow to the LA depends upon PA pressure, pulmonary vascular resistance, the inotropy of the right ventricle, and LA pressure. And PVR determines the LA filling as well as the right ventricular function. Pulmonary circulation is basically intrathoracic, and ultimately what happens is RV afterload will determine the LV preload, and we'll see how it determines it. So what happens to the RV afterload with respect to ventilation? It depends upon whether you are ventilating the lungs at functional residual capacity or not. And there are other things existing at the same point of time, which is increasing your pulmonary vascular resistance. So you try to keep the lungs in your functional residual capacity. So what happens to the left ventricular preload? So if you see, the left ventricular preload depends upon definitely RV in the form of what is an RV loading, how much blood is coming into the RV. What is an RV systolic function? How much blood is getting ejected from the RV? Pulmonary vascular resistance, and again, what is happening to the RV transmural pressure during the diastole, because it all depends upon how much its blood is accommodated into the RV. Because of that, it will eject into the circulation. Ventricular interdependence, which is also a very important thing when you're talking about the RV preload. Let's talk about it. So what happens in intrathoracic pressure and RV preload? So what happens in a spontaneous respiration? So in a spontaneous respiration, RA is more accommodative. As we discussed, the transmural pressure is positive. So there is a decreased preload and stroke volume. So what we say in a pulsus paradoxus, but just wanted to tell you, we can have a questions into the mechanism of pulsus paradoxus is completely different. There are a lot of things comes into the play when we're talking about pulsus paradoxus. So what happens, the RA is more accommodative. So there is kind of a less preload and less stroke volume. So that's why there is an inspiratory fall into the blood pressure, what we call as an normal phenomenon up to 10. But if it increases, what we see it in lot of obstructive diseases, pulsus paradoxus. And slowly, once you start having the same things over the few cardiac cycles, what happens is everything try to get equilibrated in the form of increased venous return to the RA, LV feeling, and the stroke volume goes up. But what happens in a positive pressure ventilation? So it remits the RV preload. So in a positive pressure ventilation, we know that the less blood is going to come into the RA and RV. So RV afterload will be high, again, positive pressure ventilation. So definitely the less blood will go to the LA, and LV preload will go down. So if there is a less blood going into the lungs, what will happen is there will be an increased right ventricular end diastolic pressure or volume. So because of that, what will happen is, so more and blood is getting stagnated into the RV. So RV will become bigger. So intraventricular septum, which should be stable or probably in the center, which will start bulging into the LV. And because of that, what will happen is the LV volume will go down. So LV volume will go down, and because of that, the LV compliance will go down. This is called as the diastolic interdependence. If the right ventricular end diastolic volume goes up, it will hamper the left ventricular end diastolic volume. And we remember that at the same point of time, LV and RV is very, very well connected with the alveoli and the free wall of a pericardium. So because of that, the pulmonary pressure is also going to cause a lot of pressure over the free wall of the myocardium. So what is happening in the positive pressure ventilation? If it is not in the FRC range, so what will happen is the RV afterload will go up, decrease in the LV preload, and right ventricular end diastolic pressure will go up. And because of that, the interventricular septum will go into the LV. So same thing is manifested here. So what is happening is we have a systemic venous return less, RV inflow is less, pulmonary venous return goes down, left ventricular feeling goes down. Again, LV compliance goes down because we said there is a more blood into the right side of the heart. So it is going to cause, so if you see there is a more blood into the right side of the heart, and the intraventricular septum, which is bulging into the RV, now it is straight. Sometimes we call it a D-shaped LV. And because of that, the LV volume goes down, and we know that the amount of blood pumped by the LV depends upon the myocardial length. And here, definitely the myocardial length is less, and left ventricular end diastolic volume is less, so the less blood will go outside. This is called as a diastolic interdependence. So same thing as we told about, the RV is getting tense, so it is causing pressure over the alveoli. So the things to be kept in the mind is, again, same thing we are talking about, increasing the right ventricular systolic pressure and diastolic pressure, volume. There is a displacement of the intraventricular septum. The LV volume will go down, and subsequently the LV stroke volume will go down. One thing which is very, very important here is, more and more RV become tense, your coronary perfusion pressure will go down, because remember, the coronary perfusion pressure is a difference between diastolic pressure and the RV end systolic pressure or LV end systolic pressure, and the coronaries get perfused into diastole. So more and more diastolic pressure in the left ventricle or right ventricular will go up, so coronary perfusion pressure will go down. What about the systemic ventricular interdependence? One thing which is very, very important to understand is, there are concentric fibers which are present around the left ventricle and right ventricle. So when the left ventricular contracts, it helps the right ventricle also to contract together. So what it says is approximately 40 to 50% of the outflow from the right ventricle comes from the left ventricular kick. So this is called as a systolic ventricular interdependence, and this is because of the concentric fibers. And that is the reason, if you see in the severe pulmonary arterial hypertension, we start using very high vasoconstrictor. The reason behind is, if your left ventricular function is good, it will help right ventricle also to constrict together and eject the blood. So what things to be kept in the mind when we are talking about the systolic ventricular interdependence is, we have to get the things, left ventricular end diastolic volume is less. So the left ventricular ejection fraction is less, what we talked about it when we have a tense right ventricle. So this is mainly because of the decrease in the right ventricular ejection fraction and the right ventricular end diastolic volume. As we know, the right ventricle is more tense, and if you don't take care of these things in the form of by reducing the or helping the right ventricle with inotropy or reducing the diastolic pressure in the RV, this vicious cycle will go on, and ultimately the cardiac output will fall. So this is very important to maintain the left ventricular integrity by either you can say giving an inotropy or increasing the systemic vascular resistance, which will help left ventricle to pump more, and ultimately it will help the right ventricle also to pump more. So after understanding about the left ventricular preload, what happens to the left ventricular afterload? It is very easy. So this is a diagram which will summarize most of the left ventricular afterload. So you have an intrathoracic space, and you just imagine this is a ventricle, and the 100 pressure into the aorta, and the outside pressure is 0. So what is happening? The transmural pressure is 100 minus 0, which is 100. Then you have a second scenario. What happens is, you can assume it's a negative intrathoracic pressure bleeding or spontaneous pressure bleeding. So you have a negative intrathoracic pressure of minus 25 and an intrinsic pressure of 100. So what will be the difference between the two is 100 minus 25, 125. That means the ultimate transmural pressure is high. So the left ventricle has to pump the blood against, not against 100, but against 125. So that means I'm increasing the work of a left ventricle. Then we have a third case scenario. You can assume it's like a positive pressure ventilation when you are giving a 20 pressures. So you have a pressure of 100 and 20. So the effective transmural pressure is 80. That means the left ventricle has to work against the pressure of 80. So that means it is causing a deloading of a left ventricle, or it is helping the left ventricle to pump the blood against the pressure of 80. This is the basically physiological basis for using CPAP, BiPAP, or positive pressure ventilation in left ventricular failure or myocardial failure. And again, we are talking about a vasodilator therapy. What we ultimately target the reduction of aortic pressure rather than the pulmonary pressure when we want the left ventricle to pump the blood into the aorta. This is a vasodilator we usually use when we are talking about a left ventricular failure or myocardial failure or myocarditis. So this is basically a left ventricular elastance curve. not going into the detail of that, just a simple thing. Normal, what you can say is you have this dotted line. And once we see that we increase the afterload. Afterload means we are making the aorta constrict, or we are increasing the, you will say SVR, the myocardium itself adjusts. So if you see, there is an improvement in the left ventricular volume as well as the pressure. So this tangent to all those things is called as a elastance. And every myocardium has its capacity to work against a pressure in the form of increasing the SVR and volume. But if you continue giving more pressure and more volume, ultimately this curve will start going down and it will fail. This is called as a left ventricular elastance curve. So it all depends upon whether you have a pressure overload or probably a volume overload. So what happens in the LV dysfunction is left ventricular end diastolic volume goes up, stroke volume goes down, and afterload is decreased. So there is an improvement in the relative cardiac output when we are giving a positive pressure ventilation in left ventricular dysfunction. So the net effect of positive pressure on cardiac output is, as we discussed, the right ventricle preload will go down. Right ventricular afterload, increase in the right ventricular afterload and decrease in the stroke volume. There will be a decrease in the left ventricular compliance and decrease in the left ventricular afterload. This is an effect of positive pressure ventilation on cardiac output. And there are preload dependent situation in the form of hypovolemia, volume responsiveness, which we have to see depending upon the situation of a child, and afterload dependent in the form of congestive heart failure, poor LV contractility, or there is a definitely change into the RA pressure. These are afterload dependent variables. Again, we touch based of all those things in form of left ventricle. So I would not talk about it, but this is an effect of the positive pressure ventilation on LV as well as RV. So effect of positive pressure ventilation on the ventricular dysfunction. So after understanding the effect of this ventilation on RA, RV and LV preload and afterload, how it is translated into the clinical application. So everybody knows about pulse pressure variation. So what is pulse pressure variation is basically, again, if you see, it's kind of a pulsus paradoxus. And there are ways of identifying the pulsus paradoxus with respect to the variability into the breathing pattern. So there are standardized formula. I'm not going to go into that. What I'm going to talk about is the pulse pressure variation is basically an extrapolation of a cardiorespiratory interactions, where by understanding the cardiovascular interaction, we try to understand whether we can give more fluid bolus in this condition and whether the fluid bolus is going to have any physiological response in this child. So inspiratory fall into the blood pressure depends. Why it happens is, as we discussed, there is a left ventricular afterload goes up because the transmural pressure is higher, and the left ventricular preload goes down because RA are more accommodative, and because of that there is an inspiratory fall in the blood pressure. But once you become volume deficient, this inspiratory fall becomes more and more obvious. And what happens is, what we say is the pulse pressure variation, some literature says 13, 15, but approximately 13 to 15 we accept. If the pulse pressure variation is more than 15, that means there is a room for giving more fluid bolus. And over the time, there is more research and literature over this pulse pressure variation. And what they found out is end expiratory occlusion pressure. That means if you do pulse pressure variation at the end of expiration, it becomes more sensitive, and you are able to identify the fluid responsiveness even with the change of a 7 to 9%. So when we are talking about a pulse pressure, normal pulse pressure variation, 15%. If it is more than 15%, that means you are fluid responsive. When we are talking about end expiratory occlusion pressure with respect to the pulse pressure variation, then it becomes 7 to 9%. So let's talk about this case. Again, this is a child who became very sick, severe community acquired pneumonia, had tachycardia, little bit of lower blood pressure, but still for 1 year, okay. And the child was pretty hypoxic. So basically came with a community acquired very severe pneumonia with respiratory failure. And the child was planned for rapid sequence intubation, received some midazolam, morphine. And immediately after giving midazolam and morphine, what has exactly happened is the blood pressure crashed. This is a common scenario which we see. And there are multiple reasons we go through when we see there is a crash in the blood pressure. The child became tachycardic, the central and peripheral pulses came down, and child became hypotensive. But the saturations were fine. So what has exactly happened in this patient? So again, what happens is a cardiorespiratory interaction comes into the picture. So what has exactly happened? We gave we gave what you called midazolam, which is a vasodilator. So what has happened is the venous capacitance went up. So as we discussed, the mean systemic feeling pressure went down. So that means there is no drag of this blood should go into the RA, because now my tank is bigger. So another thing which happens with the morphine fentanyl is down regulation of catecholamine surge. So what happens? There is a catecholamine surge which is keeping the vessels constricted and the venous capacitance maintained, that has gone down. So there is a peripheral pooling of the blood, or you can say there is a relative hypovolemia. Then decrease in the venous returns. So what has happened is now you start having positive pressure ventilation. So intrathoracic pressure is high. So because of that, what happens? The RA transmural pressure is more negative. So it is less accommodative. So less blood is going into the RV and less blood is going into the LA and LV. So the blood pressure falls. So as I told, relative hypovolemia and decrease inotropy. There are a lot of things we do which causes a decrease in the inotropy, which could be medication, paralysis, a coronary perfusion pressure. Because if you see in this child, the diastolic pressure was 26. So you're going to have fall in the coronary perfusion pressure. And these are all the reasons to have a hypotension. So how to manage that? So always in this scenario, keep the bolus in hand if you require. Inotrope should be in line, and probably you can push 10, 20 ml per kilo and start early inotropes. Lot of units, what they do, they start a smudge of an inotropes and get the child intubated, and if the things are fine, they stop it. Another thing which is very important, once the child is intubated, we try to aggressively back, because we know this child is a severe pneumonia, and we don't realize that there is a component of an obstruction also in this patient. So the intrathoracic pressure goes high, which itself again decrease the venous return. And always remember to optimize sedation. Just don't push the boluses like 1 milligram, 2 milligram per kilo, which would probably help us in taking care of the venous capacitance. And it is always better to anticipate and prevent rather than manage this complication, because sometimes you ended up in giving a lot of medications without having a positive response. Another case. So what is happening in this? Again, acute severe febrile illness on mechanical ventilation in the ICU. Child was completely comfortable over some ventilatory settings, and suddenly child started developing poor peripheral perfusion with hypotension. So definitely when we see this kind of a scenario, we talk about hypovolemia, worsening sepsis, pneumothorax, or myocardial dysfunction. So what happened in this child? The chest X-ray and USG was not suggestive of pneumothorax, but echo. What has happened in the echo? The IVC was full. There was a RV dysfunction, moderate RV dysfunction. There's a D-shaped right ventricle with mild TR and moderate pulmonary arterial hypertension. So what this child is having is secondary pulmonary arterial hypertension with RV dysfunction. So how to manage in this kind of a scenario? If you see, there is kind of a algorithms, I would say. So you have a pulmonary arterial hypertension and RV pressure load. What happens is once you started having increased pulmonary vascular resistance, the blood flow from RV to the lungs will go down. So RV pressure will go up. So RV end systolic and end diastolic pressure will go up. Once it is going up, what will going to happen is you started having an increase in the size of the RV, and you start having a TR jet. The interventricular septum, which should bulge into the right side, start becoming stiff or straight, and slowly it start getting bulging into the left side. And ultimately what happens, the left ventricular outflow also go down. And over the time, if you don't try to take care of these things, the RV pressure becomes so high that the coronaries are not able to perfuse the RV. And then you started having, if you see a clearly ECG, you started having ST segment depression and angina, and ultimately you go into the cardiac arrest. So in this kind of a scenario, it is very important to take care of the things. So how do you take care of the things? So how to take care of the things? So there are some rules for managing pulmonary arterial hypertension. As we say, try to ventilate in the functional residual capacity, avoid too much of a PEEP. Okay, keep your pH in the range of 7.4 to 7.45, use liberal oxygen. And if you are not able to take care of all those things, you can start utilizing your pulmonary vasodilator therapy in the form of milrinone or inhaled nitric oxide, and still you are not able to manage the situation, then the ECMO becomes the last resort, where actually you are trying to help the myocardium. So this is another case. Again, previously healthy child, not had any feature suggestive of any congenital heart disease, acutely became sick, started having breathing difficulty, saturation was 92 in the room air, and the circulation wise, the child had an extreme tachycardia, CFT was prolonged, there was a gallop rhythm, and both the perfusions were low, and the blood pressure was fairly maintained. So what exactly we're dealing with? Probably myocardial failure or myocarditis, because this child is having a gallop rhythm and the child was not able to maintain the perfusion. So what has happened in this child is child required intubation, positive pressure ventilation, simultaneously a bolus of 5 milligram per kilo ml per kilo of fluid was given, and started on inodilator and analgesia. So how it manifests, what we discussed about left ventricle is, there is a left ventricular increase afterload. If you see, the blood pressure in this child was 78. So what happens is endogenous catecholamines comes into the picture, because they have to maintain the mean arterial blood pressure. At the same point of time, the LV is not able to pump blood into the vessel. So what happens? The LV and diastolic pressure goes up, LA pressure goes up, and it back pressure into the increased water into the lungs. So what happens because of that? Lung water and decreased compliance happen. There is an increased work of breathing, so there is a negative intrathoracic pressure. The pleural pressure swings happens. At the same point of time, you have a primary myocardial injury. So what happens is there is an increased myocardial oxygen demand and consumption. And at the same point of time, child is excited, stressed, agitated. Again, your myocardial oxygen demand goes up. So in this kind of a scenario, if you continue that child to be on the spontaneous respiration, what will happen is there will be increased RV preload, increased LV afterload, and it will exacerbate the LV dysfunction. So how to help them? So as we rightly intubated this child to decrease the left ventricular afterload. So how it helps? So positive intrathoracic pressure, what will happen is the LV afterload will go down, as we discussed, because it's a positive pressure inside the, for this child, the systolic pressure was 78. Let it be positive pressure P, we are keeping 7. So the LV afterload will be 78 minus 7, it will be around 70. So definitely the left ventricular stroke volume will go up. There will be a better LV ejection. Again, we are taking care of the respiratory muscles, so there will be an unloading. The alveolar patency will be maintained and the FRC will be better. So definitely the RV afterload will go down. So more and more blood will go into the LA. There will be a less myocardial oxygen demand because of we are on ventilation, sedated nicely. There will be a redistribution of the cardiac output to the other vital organs. And there will be a better ventricular interactions, because you are not letting the LV to fail. As we know, more than the 50% of the cardiac output of RV comes from the LV. So if your LV is doing good, probably your RV is going to. So these are the kind of an indication where positive pressure ventilation helps. It could be non-invasive, it could be invasive. So at the end of the day, what I wanted to say is the positive pressure ventilation is very important for LV, but at the same point of time, it is a double-edged sword for RV. And the understanding the cardiorespiratory interactions is very important when you think about any child who is on ventilator, who is requiring inotropes or fluid boluses. And if you try to understand the cardiorespiratory interaction, it becomes very easy for you to manage your ventilatory settings, to manage your fluid boluses, and take an adequate help of inotropes early rather than later. Thank you.
Thank you, Parag. So it's always exciting and interesting to listen to you talking. Your knowledge of physiology just always blows me away. And I think what's important is taking that information and taking it to a bedside, because I'm sure there are quite a number of trainees on the call. And for me, I think one of the best places that I sort of experience and really enjoy cardiopulmonary interaction is in the post-op cardiac surgical patients. And then I think of the ones that, you know, it's the right side, like the Fontans and the Fallows tetralogy, and then the left side, those patients who are LV dilated, and how my ventilation strategy might manage to improve the cardiac output on those patients. Because at the end of the day, it's all about demand and supply and oxygenation in your tissue. I know in the general or specialist pediatrics, the pathology that makes us think a lot about cardiopulmonary interaction is the asthmatic, especially those asthmatic patients that are bordering on intubation, and most of them we end up, you know, sort of using non-invasive ventilation. I don't know if Briseda has experience in want to discuss her experience. I know she has experience. Want to discuss her experience in managing those general pediatrics patients, like the asthmatic patients, and what's her thought process around cardiopulmonary interaction when she's at the bedside for those patients. Brasida?
So the question is about my experience in airway obstruction, like asthma in the general pediatric ward and positive pressure ventilation, right? Yeah, so initially when we started, we didn't use much positive pressure ventilation, thinking that, in airway obstruction and the asthma, you have dynamic hyperinflation and you already have a lot of auto PEEP, right? And at CKIS, we use a lot of salbutamol infusion. And with salbutamol infusion, we didn't have to use as much positive pressure ventilation. However, we more and more learned that even in those types of patients, sometimes positive pressure works. And sometimes maybe it decreases their work of breathing, sometimes stents the airway, and sometimes matches their auto PEEP. Now the thing is that we all know about the physiology, and but sometimes, and Parag is a gifted teacher, and he did a good job of playing the different interactions. And sometimes what we expect at the physiological level, there are multiple things that are interconnected with each other that might be positive in a patient and negative in one. And so what I would tell people is we make an educated guess about what we know about physiology and what the physiology would be of this patient. However, there are things that we sometimes don't understand or we haven't taken into equation. And I can't stress that enough, that there's nothing like sitting beside their patient and looking at all the maneuvers that we do, what effect they have on a patient, and if they have the effect that we don't desire, then reconsider, think about physiology again, and then maybe do something else. So that would be my spiel on that. And but we do use, Zaf, coming back to your question, we do use a lot of positive pressure now, especially if the patient have a lot of work of breathing. And another thing we use in those asthmatic is that we know that more is inflammatory asthma because it's viral induced. And those guys develop a lot of microatelectasis and airway obstructions because of the cells. And most of the cells, because it's inflammatory, they're neutrophils. So we use a lot of Dornase as well as inhaled. Yeah. And there are some questions as
Yes, please.
Yeah. So coming back to that, so I think when I completely agree with Brasida, and I'm sure Parag does the same with his trainees, is that you have to be at the bedside because you can read the physiology, but putting the physiology into action at the bedside, it varies as the patient, and your patient can have lots of other issues. I think what's important to remember is that, especially with those asthmatic patients, as Parag beautifully described, the transmural pressures, you need to think about that great negative pressure, intrapleural pressure, and those patients, you need to sort of fill them, because although you're heading towards intubation, you probably need to fill them to ensure you have a good drive-in pressures from a hemodynamic point of view. So Parag, in terms of, I see that there's some questions that generating, which is great. We'll come to those. But
Zach, can I make another comment?
Go.
In asthma, and then Parag maybe can. So in asthma, you are in a bit of a tamponade physiology. It's like because it's very hyperinflated. And then the other thing is that in asthma, you have huge pressure swings with your inspiration because they're breathing so hard that sometimes they're inspiratory. You can have negative pleural pressure or sometimes minus 50, right?
Yes.
So that is another hard line. Yeah, sorry.
Yeah. So it's in this asthma, there are two ways. In the initial phase of an asthma, when you're having a more negative intrathoracic pressure and pleural swing, so the transmural pressure comes into the picture where you have probably a minus pressure of 20, 30 also, and your transmural pressure increases and RA become accommodative. But slowly what happens, this negative pressure is overturned by the obstructive components because your alveolar pressure is going very high. So over the time, this negative intrapleural pressure goes in a different direction and then you started having the high intrathoracic pressure because of the obstruction. And then the volume becomes an issue because you can't push too much. And then you have to balance the things, because simultaneously what is happening is you are getting tachycardic because of the levosalbutamol. So you have to take care of the tachycardia. Why? Because your tachycardia increases, your diastolic time decreases, your feeling decreases. So as Briseda said, it's not just about the intrathoracic pressure. Simultaneously, all the salbutamol is going to cause left ventricular, or SVR is going to go down because you are giving the beta 2 agonist. So it's a complex play between these two. And again, in asthma, if you're requiring more than 20 ml per kilo fluid bolus, I would, in fact, this is kind of a general thing. It is better to use some low dose inotropes rather than pushing them with a lot of fluids, because ultimately this fluid might go into your lungs. And second thing, which is very important, is if you go into the physiology of pulses paradoxes, it's really, really interesting. It's not the simple what we think about. The first physiology is RA becomes more accommodative because, as I told, the transmural pressure is more, so more accommodative. So more accommodative, what is happening is then the blood go into the RV. So the blood goes into the RV because RA and RV are more accommodative. There is a more volume into the RV. More volume into the RV, and the intraventricular septum now becoming kind of a straight rather than going into the RV. This is happening beat to beat, okay? As we know that we are breathing at 20 rates, but the heart is at 100. So then the RV, like intraventricular septum is straight. So what has happened is the LV volume has went down. And you know that you are in the spontaneous breathing, or probably a negative pleural pressure breathing. So your left ventricular afterload is less. So what is happening is the stroke volume is going down. So you have an inspiratory fall in the blood pressure. But the mechanism of pulsus paradoxus in cardiac tamponade is completely different. The mechanism of pulsus paradoxus in asthma is completely different, because in asthma, the another thing comes into the picture is increasing into the pulmonary vascular resistance. So if you go into the mechanism of pulsus paradoxus in each and every physiology, it's different.
Excellent. There is a question here from David. What consideration would we have in the obese pediatrics patient when it pertains to cardiopulmonary interaction? And in practice, what level of PEEP do you recommend the use of inotropes in the patients with mechanical ventilation? So if I first to address that, and we can open it to both yourself and Briseda. It's not, I think, again, when you're thinking of the use of PEEP and your strategy of ventilation, you have to think of the pathology that you're managing. So I wouldn't particularly say I have one PEEP value for a patient. It would vary, depends on the sort of pathology that you're managing. And even though the patient is obese, we need to still remember that they have very fragile, well, not fragile, the lungs is within the thoracic cavity. So you need to think about ventilating the lungs rather than the mass of the patient, is my take on that. I don't know what you guys your thought process is at all.
I'll let Parag explain that, but I think maybe he's getting it with obesity. You know, your transpleural pressure is very high, right? And so your transpulmonary pressure is going to be low, and you need higher levels of PEEP. But Parag, over to you.
Yeah. So two things when we're talking about obese patient. One thing you have to consider is body surface area, because there are a lot of obese with 10 years old, 50, 60, 70 kg. You can't put the rules of whatever we use as a fifth percentile blood pressure in this way, because most of them, if you see, their blood pressure on the higher side because they have a higher body surface area. That's one thing. Second thing, which is very important in obese, is transthoracic pressure. So they really have a high transthoracic pressure. So to displace the bigger chest, you require more transpulmonary pressure. So this is second thing. So in this patient, from cardiorespiratory point of view, most of things will get nullified, because whatever the things you see on the ventilator, probably they require more pressure to displace, but ultimately the driving pressure, which is very important, the PEEP very important. These two things would not change whether the patient is obese or not obese. So you don't have to really worried about these two things. What you have to really worried about, if you're talking about a ventilation, the displacement pressure, or I would say transthoracic pressure. That is one thing. And PEEP, what Zaf said is, yes, it doesn't depend upon what inotropes is going to use for a PEEP. But remember, you have a shock patient and where you are using a very high PEEP 510, so and you have given an adequate fluid resuscitation. Again, the current pediatric sepsis surviving sepsis guideline also says around 40 ml per kilo you can use it, and then consider early inotropes. Very clearly they have written consider early inotropes than the late. And always remember that starting inotrop doesn't mean that you have committed yourself to continue the inotropes. You start the inotropes, it might reduce your fluid bolus, wait for 6 hours, see the sinks, and you can come down and stop it.
Exactly. And you have to be at the bedside to manage that. So one of the things that you probably, as working in a cardiac center as well, Parag, and Brasida as well, you have the patients with the Fontan and the Fallows tetralogy patient comes back. And you probably, one of the things that you might hear from your surgeon is that, right, we need to get them extubated early. We need to get them extubated early. And there's a drive in some centers, for example, in Texas, where they bring back their Fontans and their Fallows and they try to extubate them early. Can you explain to the trainees and the audience online why there's a drive to extubate those patients early, the right side lesions, as it pertains to the discussion you've just had with cardiopulmonary interactions?
So when we are talking about Fontans, or mainly the physiology which is gonna help you to learn everything, is what Zaf said is tetralogy of Fallot. So what is a basic thing in tetralogy of Fallot is you have a right ventricular hypertrophy, and because of that the right ventricular volume is less. Second thing which we have to understand is, because you have a more muscle mass on the right side, when these kids go on a bypass, if you see the normal physiology of or normal positioning of the heart, RV is kind of an anterior. So once they go for a cardiopulmonary bypass, RV is the one which is going to get contact with the ambient air. So because of that, if you consider at the end of a bypass, RV is one who had a maximum myocardial injury, probably a maximum myocardial swelling. So because of that, RV become kind of a stiff, what we called as a restrictive physiology. Restrictive physiology means there is a problem in the diastolic relaxation. So once there is a problem into the diastolic relaxation, that is because of the more muscle mass and because of the more swelling, which is going to last there for a few days. So what happens is, now RV is kind of a stiff, you can say. And you know that the amount of volume ejected by the RV depends upon the size of an RV or probably a radius. So now RV has a limited capacity. So there are two ways we can do all those things, is by pushing a more blood. So if you see any patient of a tetralogy of Fallot, the first question intensivist asks to the surgeon is, what is the CVP you maintained in your OT? What is the CVP, targeted CVP you had, or RA pressure which you had to maintain the normal blood pressure? So you have to maintain the higher RA pressure when the child is ventilated. Now, why you have to maintain the high RA pressure? Remember, in a ventilated child, what is exactly happening is, in a ventilated child, the positive pressure ventilation, less blood is going into the RA. If the less blood go into the RA, less blood go into the RV. And you remember, already RV is compromised. There is a diastolic relaxation problem and less blood is going into the RV. So RV is not going to eject any blood into the lungs. If it doesn't eject any blood into the lungs, what is going to happen? Less blood into the LV, and then you landed them into the low cardiac output state. So how to manage that? When the child is intubated, we, in the initial phase post-surgery, we became kind of a liberal in giving volume. And why we want this child to be extubated? So simple things. Once the tube is out, from positive pressure ventilation, you went to the negative pressure ventilation or spontaneous ventilation. Again, what is happening is the transmural pressure over the RA and RV is positive now. They are more accommodative. They're going to relax more. So more blood will come into the RA, more blood will go into the RV, and more blood will go out. So a simple resort to all those things is extubating them. Same things happens to the Fontan physiology, because everything depends upon your RV. So if you increase the blood flow into the RA and RV, you will save the child.
Excellent. I mean, I couldn't explain it simpler than that. That's brilliant. And exactly. But at the end of the day, you know, the surgeon and the surgical team will say that. But as the intensive care team, you need to understand the play of the cardiopulmonary interaction, but you also need to be mindful of everything else that is happening around the bed space with the patient. Is the child bleeding? Is the rhythm stable?
Yes.
So one needs to not just look at the one aspect, just the cardiopulmonary interaction, but the entire management of the patient. So it's good to understand the reason behind the demand of taking the tube out early, but you need to be mindful that you're managing an entire patient and not just cardiopulmonary interaction. And it's the same thing that happens. And similarly, the patients who are, may have a severe coarctation, has a dilated cardiomyopathy secondary to the coarctation and late repair, you will look at the echo versus the patient, and you're thinking, God, I might not extubate this patient, but you can't leave the patient with a tube. And those are the sort of patients where you think in that patient on the LV, you want to give them some positive pressure ventilation because you want to support or reduce the transmural pressure and improve the afterload on the left side of the heart. And those are the patients that you will, monitor with an echo. But if you do extubate those patients, you want to extubate them onto a positive pressure ventilation strategy. Is the way I tend to manage those patients in my my practice.
Yeah, actually it's like inotrope for left ventricular failure. Ventilation is like an inotrope.
Yeah, you hear that very commonly. But it also, what it also does is that it helps to reduce. So if you probably extubate a patient that is in sort of heart failure, left side heart failure, they have their work of breathing is so increased that there's a greater demand on the respiratory muscle use up so much oxygen. So by just giving them making it easier for them to breathe, whether it's CPAP, whether it's AVO, it sort of reduced that work of breathing. So it put less demand on the LV as well. So even though it might not actually reduce your transmural pressure a lot, it allows the patient to breathe easier, and the demand on the respiratory muscle is much less. So we need to think about that. Let me see if there's any other questions in the box. Yes, there's a question, Parag. How does bedside echo help in deciphering these cardiopulmonary interactions?
Good. So two things. When we talk about echo, from cardiovascular point of view, from lung point of view. So let's talk about from cardiovascular point of view. So let's assume spontaneous ventilating child, and you really wanted to know how much fluid bolus you want to do. Everybody knows we check IVC volume, we check how the RV is looking like, it is filled, underfilled, and inotropy. So that is easy. But once we talk about the cardiopulmonary interaction, let's talk about few of the scenarios. So one is an intubated child with the peak pressures or a driving pressure of 10, around 15, PEEP of let it be 8. And then you have to think about whether you wanted to give more fluid bolus or not, or what is an exactly thing why this child is not improving with respect to the fluid bolus. So how echo will help? You put an echo probe, two things will come to know. One is whether this child is exactly having a high pulmonary vascular resistance. So a lot of time what happens, people try to search for TR jet, but these are the things which will come a little bit late. And these are very common in adults as compared to the pediatric, because adult hearts are less accommodative. Pediatric hearts are more accommodative. They have a dimension change is little bit possible in pediatric heart as compared to the adult heart. So that's why you'll not see the TR jet. But how it will help you is you see the interventricular septum. So if you're seeing interventricular septum is kind of a straight and it's not going into the right side during the systole, that means your RV pressures are almost, I would say, 2/3 of systemic. So in that scenario, how it's going to help? So you think about other strategies. That means, are you over-ventilating the child? So let's come down on the PEEP, let the child comes to the FRC. Again, we don't know what is an FRC, but you try to play with your PEEP without changing the oxygenation. Second thing, what you do is you try giving us some inotropy, because you know that RV is something which is going to fail over the time. Third thing, you can consider pulmonary vasodilator. In the sense, you can talk about milrinone if your blood pressures are maintained. So a simple echocardiography has helped you to see what you have to do. Either you have to give a fluid bolus, inotropy, inodilator, or start some pulmonary vasodilator. This is one scenario. Second scenario, non-ventilated PEEP. How cardiopulmonary things is going to help? Let it be, you're talking about a myocarditis situation. In a myocarditis situation, you saw, again, it's very difficult for us to understand, but there are a lot of things where we can calculate left ventricular end diastolic volume, and you see the LV is looking bigger, LA is looking bigger. That means you are dealing with something related to the LV failure. In this kind of a scenario, stop using more fluid boluses, start utilizing inotropy, and if you have a good blood pressure, start getting some inodilator so that you can take care of this cardiopulmonary interaction. And in this scenario, even without starting any respiratory support from echo, you'll come to know my LV is failing. I should consider some kind of a positive pressure ventilation in the form of a BiPAP or CPAP, even before the child goes into that phase of a complete kind of a respiratory distress and respiratory failure. So this is the 2-3 scenario where the echo would help you to guide both respiratory treatment and cardiovascular treatment.
Yes, the echo, a stethoscope, and touching the patient and examining the patient. Because in some area, you don't have the ability to get an echo with a click of a finger, but what you can do is to assess your patient and go back to your basic, a medical school teaching, feel for the liver, listen to the chest, you know, those sort of things. There's a nice question here from someone. What is the role of non-invasive ventilation in a patient with pneumonia on inotropes with stable blood pressure? I think sometimes in the intensive care, we get the patients that are much sicker. But in regional hospital, you might have a situation where you have a patient that is at this level. And I wonder, Braseda, if you were called through from one of the distal hospital in Canada, and this was the situation you were given, what sort of advice would you offer to the local team?
I think, Zafid, goes along the lines again of what is the context, right? How comfortable are those? What type of patients can they look after, right? So if the patient is on non-invasive ventilation and the child is actually tolerating the non-invasive well, they're alert and they can do their own airway toilet and cleaning, and the inotrope requirements are not very high, and the physician and the nurse there, the team looking after them, is not as comfortable intubating or knowing what might happen when you intubate a child, then you let the child be, and then you actually send your transport team there. But you also tell them that, you know, things can change at any point, and at that point you kind of have to prepare them. What should they have ready? And if things change, then the situation became more unstable, then I would ask them to call me, and so we can do step by step. And you've done this before many times when you were at SickKids with Parag. I think going back, Zaf, you said that sometimes, you know, we use positive pressure for the work of breathing, right? And because the work of breathing is huge and put like big demands, and we give positive pressure to actually help with ventilation and oxygenation in terms of the lungs. And so if you have achieved those with non-invasive ventilation and you have a bit of inotropes running, that's not a big deal in my mind. I can wait. But be very careful that I monitor the patient carefully so that if things look like they're not working, I am ready to jump. That would be my.
Yeah, no, absolutely. I completely agree with you, Braseda. And I think of recent with this pandemic, what we have found is that the patient with the PIMS-TS or MIS-C, you know, as you guys call it across the pond, we've had a number of patients that was referred to us like that, because I do also work for the transport service. And in fact, those patients, we try not to intubate them because, as Parag really nicely described, the complication that you can have when you have a patient and you haven't managed them from a, you know, cardiopulmonary interaction and having an adequate driving pressures. And intubating those patients probably can put them at much higher risk. So by using just a bit of non-invasive blood pressure and some inotropes, if you're maintaining good cardiac output, you're checking their perfusion, you're checking their lactate, if you have the ability to check a lactate and blood gases, you're checking that they're peeing adequately, you're checking their level of consciousness is appropriate, I would absolutely advise, like Braseda, don't rush to put the tube into the patient, because by sedating the patient, like Parag beautifully showed in example number 1, after the morphine and the midazolam, you completely change the whole interaction. And now you've moved a patient that was reasonably stable to quite unstable. So one needs to think about those things. As you become more senior, doing procedure is the decision that you have to make. It's easy to put a tube. As you become more senior in your practice, not putting the tube is a more difficult decision. And you need to justify that. I tell my trainees and I ask myself, if I'm going to put the tube, why am I putting the tube? Am I just putting the tube so I can paralyze the child and they don't cry or move around? Or am I putting the tube so I can make a difference to the cardiac output, to the cardiopulmonary interaction? And that is the question you need to ask yourself. Parag, anything you want to say about that?
Can I just say
So,
something
yes.
else before Para, and then I'll
Yes, please.
I couldn't agree with Zaf more. And one of the things in the current pandemic, we know that initially the fashionable thing to do is to intubate people early. And we were short of ventilators and the outcomes were not that good, right? And so I put in the chat a latest editorial from Martin Tobin. Of course, we all know Martin Tobin, hero of the Bible, the mechanical ventilation book, right? And he's written many editorials that are actually amazing to read. And he most certainly wrote now, the latest one was in the European Respiratory Journal about use of non-invasive, because a lot of time, like, you know, everyone for COVID says from high flow, go straight to intubation. And it's a very nice editorial that goes through how that is not the case, and it's the patients who drive that. And it's your clinical judgment as a clinician. And, you know, I put the link, so would be if people are interested in reading. Over to you, Parag.
No, actually, it's an interplay between the two. What I said to my fellow always is, when you are telling yourself, I'm not going to intubate this child, that means you have already committed yourself, this child needs intubation. When you are telling yourself, I'm not going to intubate, I'm not going to intubate, that means this child needs intubation. That's one thing. Second thing is, there is something called as, you might be knowing, Friday ventilation. You know, Friday night ventilation concept. So when you are actually seeing the child on the Friday evening, no, this child will deteriorate in Saturday and all those things, it is better to put the tube, okay, ventilate them and extubate on Sunday. Extubate on Monday. So Friday night ventilation, I think so it is Lauren Brochard who had that article, Friday night ventilation. So again, if you ask, it's like a pathway between the two. Depends upon that. You can't become too much like, I'm not going to intubate this child. I'm not going to intubate this child. So if requires, take your clinical decision and intubate them, support them. But at the same point of time, at this moment, we know what Dr. Briseda said is very, very important. Any child who needs intubation, invariably, very rarely, if they're crashing in front of you, you definitely give a trial of heated high flow or a non-invasive ventilation. I think so very rarely anybody will be there who straight away put a tube. Most of the time we really want them to have a kind of a situation where they can actually breathe on non-invasive.
So there's a question here, Parag. I probably think you probably are best fit to answer. What is the tidal volume you target in ventilated child, current body weight or ideal body weight, in an obese child and in a malnourished child?
If it is an MCQ, the answer is ideal body weight. Okay, it's an ideal body weight, but at the same point of time, remember, it's not about the tidal volume. Currently, it's all about the driving pressure, one thing. Second thing is whether you are able to achieve the physiological goals in the form of optimum oxygenation, probably optimum ventilation, and with minimum pressures.
And I think that brings me to the second question, because I think sometimes when you're ventilating patients, you think about the injury that we can cause, bar trauma and all the other trauma to the lungs, and then you sometimes need to put these patients on ECMO. So there's a question here. It's Sujit from the ECMO team.
Yeah.
Sorry if I pronounce your name wrong.
That's fine.
Really apologize for that. How can you select the ventilation support if the baby undergo goes to respiratory failure? Do you understand the question? I'm not sure.
Yeah, Miss, actually, but I would just answer generically. The respiratory failure, everybody has to understand respiratory failure doesn't mean intubation, non-invasive. Simple definition of a respiratory failure is you're not able to maintain the saturations more than 94 and you're requiring more than 50% of oxygen. It could be a hypercarbic in the form of you require the PaCO2 is more than 65 or 20 from the baseline, then PF ratio, and anyone who is requiring non-elective respiratory support. So, remember, it is like inotropes. It is the ventilation is also disease. It's not a disease specific. It is physiology specific. That means you have a bradypnea, you have a cardiopulmonary failure, you're going to intubate. There is no way. But if you have a respiratory distress, the reason is wheezing, you're going to give nebulization and decide. If you know that in spite of nebulization, there is a moderate work of breathing, depending upon if the child is kind of awake, the encephalopathy is not there, probably you give a trial of heated high flow. And when you know a child who is having a work of breathing, a little bit drowsy, and you don't feel that he is going to breathe so nicely, he's going to tire out, probably non-invasive ventilation is must. But the rule of thumb, everybody should remember, all the fellows, is any condition is there where you require pressure. That means you know that you require PEEP or PIP, don't try heated high flow. Then they straight away go for BiPAP or CPAP. Yes, sometimes to buy the time you can start heated high flow and see the child is improving or not. But you know that there is any kind of a neurogenic issues where you really wanted to push the air into the lungs, choose non-invasive in the form of CPAP or BiPAP rather than heated high flow.
So I think we've spent a nice little time discussing. We've you've set out the physiology beautifully. You've used some case to demonstrate the pathology and how we make use of the thought process from cardiopulmonary interactions. And then we've discussed a few examples and share our experiences. I think it's been a fantastic 2 hours or so. And of course, it's absolutely great to see Braseda and yourself and to share this platform. So I'm going to ask you guys to give your final thoughts on it, and then I'll let Sairam summarize.
One thing just before things, one question for both of you, Dr. Braseda and Sairam. So very interesting question. So once we go on VV ECMO, let it be a child with the respiratory failure goes on VV ECMO. And now you started having a tense RV because you started them on a rest setting, and probably the rest settings might be increasing your PVR, or probably the rest setting is not enough to put the child on functional residual capacity ventilation, and the RV is getting tense, and probably you're seeing a D-shaped left ventricle. What you do in this scenario? So how do you manage ventilation in this scenario? Or you go on VA ECMO, or you start inhale nitric oxide?
So do you want to go first, Braseda? Go first, Braseda, and then I'll answer.
Yeah, so Parag, you know, one of the questions you just answered said, look at what is the problem, right? In respiratory failure.
Yeah.
So the same would be like, you know, I would look as why is this RV failing, right?
Yes.
And it's most likely the lung. And I know that we talk about the resting pressures, and but those are just like the resting pressure. We have just like decided
using it. Yes.
Those are going to be the resting pressures, right? And so there is a lot of experimental research going on at Toronto General Hospital from Lorenzo Del Sorbo, where he's doing with experimental animal models, pig, large models, and looking at what would be actually the best rest setting. But if you're having problem with the RV, like forget the rest setting, you have to say, how am I going to protect this RV?
Yes.
What is going on? Do I have clots, and do I have atelectasis? Do I have to actually, you know, get rid of, do some pulmonary toilet and re-expand some areas? Do I have an infection that is getting worse, and do I have to like treat with stronger antibiotics? Can I start a little bit of NO? Can I do other things to improve the RV afterload? And if all else fail, then, you know, why is the RV failing would be a question. And do you, you would go to VA, right?
Yeah, absolutely. No, absolutely. I think you've answered it. You look for the reason why your afterload is high. You try to reduce that, but don't delay, because you don't want to have a failed lung and a failed heart, having a heart and lung transplant, it's better to have one. So we will convert to VA. So
do you have a kind of a low threshold or high threshold, in the sense you've gone through all your algorithms, but still what is happening
we will
is
convert early, very early. Yeah, because you don't want to delay, because then if you strain your RV, and you remember the RV is more, it's not muscular,
Volume,
it's just
yeah.
like a flimsy thing. And if you fail, your RV's failed, then you will fail your lungs and you'll fail your RV. So we will convert. You can always convert, and then you can go back if things get better. But I wouldn't delay. Our team wouldn't delay. Of course, it's a multidisciplinary discussion. And again, you want to think that if this is a pathology that you think would have a good outcome, you wouldn't just stick the patient just to support them. If you think that whatever you were treating from the beginning, from in terms of the lungs, was going to get better, then yes. But if you think that this lungs is not going to get better, you're not in an environment where you can offer a lung transplant as the out. You always have to think, what is your get out? And if you're not in those sort of situations, then putting a patient onto VA ECMO is delaying the inevitable, which is death. And I don't think that is good for the patient, nor the family, nor the team. So those are all big conversation and decisions that you need to make. But if the specific question is, you have the capacity for VA, you have the capacity for lung transplant, then you make a decision. So a decision that will be made in Toronto in sick kids might be a different decision that I would make in my current where I am, and completely different from what you will make. And so people, our trainees and our colleagues need to understand that the decision, you can have the thought process and the knowledge and everything, and you can discuss what might happen if you were in an ideal world, but you have to bring it back to your setting as well, is my take on it. I hope I answer your question.
Yes, actually it has happened a couple of times. So what we did is we just we maintained what we saw, the cardiac output, lactate, things were going fine. So we just hold our things and kept the cardiovascular team, cardiac surgeon team ready for changing to VA ECMO. And probably we were in the range that in the few days the lungs started improving. So our RV became fine.
Yeah. So yeah, it's just again, at the bedside, you make those decisions. On a questionnaire or something like that, that would be my answer. On the bedside, I will see what is happening on an hourly to hourly, but you have your plan B rather than delay. And you share the mental model with your team, so everyone is aware of what is happening.
Yeah.
Grand. Preseda.
Exactly. Like that, again, I couldn't agree with you more. And then the thing, Parag, is that it's okay to wait if the failure or the strain is not as bad, and you're thinking that there is a pathology that is improving, right?
Yeah.
When you expect that it's a pathology that is going to stay the same or get worse, then you have to do something,
just
right?
go away.
But those are very context dependent on the patient. And then what Zaf, I cannot agree more with what Zaf said. Where is the out here?
Yeah.
And what do we need to do? Yeah. Thank you.
Thanks.
And on that note, I will ask Sairam and Nikhil to take back the screen.
It was an excellent talk and was a great moderation. Started from the history, it has physiology, and more importantly for the fellows and trainees like me, the clinical implications. Just two things I want to mention that Dr. Parag was mentioning. Dr. Parag was always very concerned regarding intubation of a physiological difficult airway. He used to make sure that NS bolus was in line and there was an inotrope that gets started before intubating a side with decreased resource. And one more thing he used to tell, we don't remember the children we intubate and save, but we always remember the children we have not intubated and we have saved. So the patient selection before intubation and now the patient selection for the decision regarding an HFNC and NIV is very important. So these are the things, sir, who teach us in the bedside. Same thing has been revised today. And at this juncture, I would like to thank from the team of PISU Ankura Group of Hospital. I'd like to thank Dr. Parag for accepting the offer to deliver a talk on cardiopulmonary interactions. And I'd like to sincerely thank Dr. giving us time and sharing their valuable knowledge on cardiopulmonary interactions. And indeed, it was not a webinar. I felt it was a grand round of cardiac rounds from unit heads. It was every case was discussed, like Fontan, why do we extubate a Fontan kit early? What do we see in the monitor? It was like a grand rounds, literally. We have learned a lot of things. Thank you everyone.
And what I would say is I've learned a lot of things from definitely Zafno and Briseda, because Briseda was one who gave me like a full hand. Parag, you go ahead and do whatever you wanted to do. Thanks for teaching, and thank you very much, both of you, for accepting the request also.
Thank you very much. It's clear that we all work together. We speak from the same hymn book many years later.
Yes.
Thank you both. Thank you, everyone. And it's very nice to see you both, Zaf and Parag. And maybe tell us your secret. You don't seem to age, both of you.
That's what I told Parag earlier.
Thank you.
Right.
Thank you.
You guys,
See you.
Take care. Bye-bye until
Thanks,
later.
Nikhil. Thanks, Sairam. Bye. Take care. Bye.
Yeah. Bye.
Bye.